to introduce our speakers for this collaborative seminar between the DC CFAR Center for Population Sciences and also the Aging and Comorbidities Scientific Interest Group. I'm Mark Siegler. I'm the co-director of the CPS core, and I'm co-presenting this, hosting this with Dr. Anne Monroe from the Aging and Comorbidities Scientific Interest Group. We have three amazing speakers tonight. I'll be starting with Dr. Siegler, who'll be presenting on integrated care models for aging and patients living with HIV. That'll be followed by Dr. Prather, who will speak on aging in general and age-friendly care philosophies and how they apply to patients living with HIV. And then we'll transition to Dr. Shepard, who'll speak on approaches her organization has taken to case management and psychological resource provisions in older patients living with HIV in DC. And our hope is basically that attendees will gain knowledge and inspiration for clinical initiatives and research projects that will benefit people aging with HIV in DC. And with that, I'm going to turn it over to Dr. Monroe, who will introduce Dr. Siegler.
Thanks, everybody. I'm so glad you're all here. We've been looking forward to this day for quite some time. So it is my honor to introduce Dr. Siegler. She's the Mason Adams Professor of Geriatric Medicine and a Professor of Clinical Medicine at Weill Cornell Medicine in New York City. She's also the Associate Program Director for the Medicine Residency at the Weill Cornell campus of New York Presbyterian Hospital and teaches on the inpatient geriatric service and sees geriatric outpatients. She's a consultant for New York Presbyterian Hospital Weill Cornell's HIV practice, the Center for Special Studies. And in addition, she's a member of the Medical Care Criteria Committee for the New York State AIDS Institute Clinical Guideline Program and the AIDS Institute's Clinical Quality Advisory Committee. Wow, that was a mouthful, but very, very, very important roles. She also serves on the scientific committee of the International Workshop on HIV and Aging. And so without further ado, Dr. Siegler, we welcome you, and we are very interested to hear your perspective on integrated care models for people aging with HIV. Thank you.
Thank you, Anne. Let me share my screen. Okay, this should work. I do want to say this is a little bit of a homecoming for me. I was born at GW, so I'm really very honored to speak here today. The map on the left is from AIDSview, and I encourage you to use the site for slides and for information. What I've graphed is the rates of people living with HIV per 100,000 total population. In this case, the age 60 plus, and you'll see that in a number of zip codes that the prevalence rates are well over 2%, and this is such an important topic, and I'm so delighted to be here and to be able to share my enthusiasm. Here are some disclosures, and this is a brief talk, but what I want to review are care needs, talk about a few programs and how they're implemented, then move to different models of care integration that are seen in the geriatric literature, and then propose some barriers and challenges. So I want to begin with a model of the components of well-being. Medical issues are only a small part of the needs of a person with lived experience, and as we develop models of care, how it's important to think about how we're addressing the psychosocial factors and the interaction of those factors on the delivery of medical care. Now, this conceptual model doesn't describe how these components are addressed, and so how can you translate those components of health into domains of care? HIV management and comorbidity care occur in the context of these other domains. We can't optimize function, we address geriatric syndromes unless we're addressing behavioral health, and unless we're addressing socialization and access to basic supports like adequate housing and food. Primary care, which is at the top, is essential to all care, has to address patient priorities, and so all of these are the way I view sort of the components of the domains of care. Our problem is that while we can do a comprehensive assessment of an older person with HIV, that doesn't necessarily translate to feasible, useful recommendations. When my colleague Tessa Del Carmen and I first did geriatric consultation for CSS, we went and did a chart review to see how many of our recommendations were followed, and it turned out to be only about a third of them. So we have to create programs that translate our observations into meaningful change. Programs have been around for a while, and the earliest geriatric program that I could find in the literature was the EMUTA team, EMUTA meaning Aging with Wisdom, and this was in New Orleans, and it was an absolute dream team. It had a geriatrician, infectious disease specialist, a social worker, a pharmacist, an NP with an interest in geriatric management. They established criteria for referral. They had a screening process, and the referral was failure in 3 geriatric domains. Those people who were referred had specific therapies for the needs that were identified, and they ended up writing about over 150 patients over the age of 60 who they when the people in charge of the program left, the program was over. And I don't think that this is every program's fate, but it's a risk, and we need, and I'll talk a little more about sustainability in the end. The literature now has a number of examples of thriving programs. You may be aware of Golden Compass in San Francisco. In Europe, there is the Chelsea and Westminster Clinic. There's Silver Clinic. There are clinics in Modena, Italy, and Madrid. But they're expensive, and we don't have a payment system that's going to support socialization and exercise and pharmacists. Usually we have to try to be realistic about what currently can be paid for, and how we might create models that allow these essential components to be available. So their implementation strategies are in use for people with HIV, but the evidence base is extremely slim for the care of older people with HIV. We've created a guidance for older people with HIV, but we had to call it a guidance because we did not have the evidence base to call it a guideline. And so we are hoping that changes the next time that version comes around. But many of the things that I'll talk about or that I'm concerned about are in their earliest stages, and we do not have a great literature to say this is the way things must be done. Well, what's out there? This is another map from AIDS View, in this case of US, and these are the starred sites are HRSA-funded HIV and aging SPINS programs. SPINS standing for Special Program of National Significance, and NORC in Chicago is helping with the development of evidence and the evaluation of these programs. New York State is funding pilot programs. They're called PAW programs, People Aging with HIV, and they've made an effort to include all of the regions of the state, as well as focusing on urban, suburban, and rural programs. programs that are university-based and even community-based organizations. The key component of these programs is case management. And again, these are early enough that we do not have data yet, but I think in the next few years there will be exciting information about their creativity and their feasibility and the people they have served. HHS has had some national HIV and aging challenges that are smaller in size, but one of the key parts of this is that there is a rural component and people who have in the past not been able to get funding for experimental programs, I think we'll be able to through this. So if we look at changing care, care models that are developed through these large grants, through SPINS grants, through other large Ryan White funded grants, tend to be the larger programs, the academic programs, and they can be transformative, but care occurs in programs of all sizes. And what we learn from SPINS or PAW and other large grants has to be translatable to smaller sites. And how are we going to get the government agencies to support and incentivize incremental change, which to me is just as valid. But let's go back a little bit and start where we're comfortable, which is the clinic. Until now, we've assumed that care should center around the primary care site, the clinic itself. And that answer may be yes, especially if it gives people with lived experience a sense of safety, but perhaps not. And so if you think of other ways to organize and provide care, and you change clinic and replace it with the focus of the clinic, which is really care coordination, we can begin to think about how those components can be reorganized. So let's break it down even into the individual components, mental health, housing, HIV care, comorbidity management, and so on. I'd spoken in the beginning about care domains and acknowledged that those domains don't specify how the care is delivered. It requires some kind of care integration. And there is a literature on care integration that's actually a good 20 years old. Lutz defined 3 levels of care integration. The simplest is linkage, and that is you just combine pre-existing services, maintaining the current payment mechanisms, and establish sort of basic connections between service providers. So that's useful for people with mild or moderate disability, and that's basically what's happening when you are communicating through your EHR and sharing notes. Establishing a relationship with a geriatric practice is a form of linkage. Care coordination creates structures and policies that coordinate the benefits and services and facilitates the transfer across the systems. That's likely the model that many of these national and New York funded programs are using. Full integration pools the resources and develops new programs that create and control not just the services and the benefits, but also, again, how all the money is spent. And it's most useful for people with high levels of disability and needs. These are often capitated programs where no one tells the site how to spend their money. What level of integration would a site be interested in? And can different levels of integration be implemented for different clients at one site? Fully integrated models, especially those that in that bottom domain there require not just the comprehensive assessment and the care plan, but they require facilitation of transitions between not just providers, but between settings and services and between healthcare settings. It requires facilitation of patient access to community resources as well as other clinicians. So what kinds of models can be used as starting points? Low and middle income countries have demonstrated that one can integrate systems and meet people where they are at all sorts of levels. And this was just a scoping review of integrated services delivery in low and middle income countries. It's not specific to HIV, but includes HIV care. And one can see that irrespective of the location and of the size of the center, that different kinds of services can be provided in ways that meet the needs of the community. A broader way to look at that is differentiated service delivery, and that has been in use in low and middle income countries as an adaptable approach to care integration. DSD is client-centered. It aims to leverage limited resources by tailoring those health services to patients' clinical statuses and preferences. The care model, again, originated in Africa, but Lauren Collins wrote a really important article suggesting it can be used for HIV care here in the US, and especially in the setting of COVID. Another
about 5 minutes.
Okay, very good, thank you. Another white paper was published by the HIV Medicine Association that looked at DSD and street medicine, that is the delivery of health services directly to unsheltered populations, as important models of care. So we need to think not only about the big university programs, but ways that we can use existing payment systems to create new models to bring care to people where they are. We can also adapt geriatric models of care, and I don't have time today to go through these, but a PACE program, that is Program of All-Inclusive Care of the Elderly, is a classic fully integrated model for dually eligible people. The Village program is one that Miley Karras has used in UCSD. NORCs are naturally occurring retirement communities where people can age in place. And I can provide the slides in case people want to look at this in greater detail. I did look at Google what DC and these are some of the resources in DC. There is a PACE program in DC. There's a Villages in DC, and I hope that you can connect with them. So optimizing clinical care faces a number of barriers we've talked about today: the lack of resources, the limited evidence base. High medication costs make it very difficult to capitate care because so much of the money can go to medications. And of course, threats to sustainability. And I want to close by saying, even as you're planning new models of care, you have to look ahead to not just the management of multimorbidity, but the inclusion of long-term care and the flexibility that will allow people with different needs to have different degrees of integration. So let me stop there, and I think there'll be time for questions at the end.
Thank you.
Certainly, there will be time for questions. Thank you so much.
Okay. Thank you so much, Dr. Siegler. And now it's my pleasure to introduce my colleague, Dr. Christina Prather. Dr. Prather is the director of the Geriatrics and Palliative Medicine division here at GW. She attended undergrad and medical school at the University of Maryland before moving to one of my favorite college towns, Chapel Hill, to do her internal medicine residency and geriatric medicine fellowship at the University of North Carolina, which happens to be where my son goes to college right now. During her residency, she was the recipient of the James Bryan Award, which recognizes physicians for their compassion, clinical skills, and bedside manner. In addition to being the division director here, Dr. Prather is also the clinical director for the GW Institute for Brain Health and Dementia, and is co-director of the GW Geriatric Memory Evaluation and Treatment Clinic, where she helps patients and their families manage the challenges of aging, debility, cognitive loss, and dementia. In 2021, Dr. Prather was awarded the Sol Katz Award by the local chapter of the American College of Physicians in recognition of her excellence in teaching. On top of all these clinical responsibilities, Dr. Prather is also the proud mother of 3 children and 1 energetic puppy. So we are excited to hear what Dr. Prather's insights into caring for people as they age and how we might apply these to our populations living with HIV. Dr. Prather, over to you.
Thank you. Mark only invited me because we have a Chapel Hill connection, I think.
I didn't know about your Chapel Hill connection. I just think that much more highly of you now.
So I actually went and grabbed another slide because as Dr. Siegler was talking, well, let me just go through and tell you my disclosures first. So I have grant funding from NIH, AHRQ, recipient of foundation funding from the Washington Home Foundation in the District of Columbia, and I consult for the Alzheimer's Association to develop educational initiatives for primary care to raise awareness around dementia prevention, screening, early identification, and treatment. So I grabbed this slide just really fast from another talk I had, which is like sometimes it feels so great, the task that we are asking of ourselves when we think about going from linkage in care to full integration and really comprehensively thinking about caring for our HIV or any population of individuals as they're aging. And then when you add on physical or cognitive disability, medical complexity, it's like trying to like jump over this like massive divide, right? And it's just so important that we come through thinking about how we do it together. And no one individual can do this alone. I'm preaching to the choir here. But what I hope you'll take home from my short time talking today is that there are things that every single one of us can do as we interact with aging individuals in the health system. And so several years ago, the Hartford Foundation and the Institute for Healthcare Improvement came together and said, we can't do this in geriatrics alone. We can't do this in these expensive interdisciplinary clinics. We can't do this the same everywhere. So every health system, we will challenge you to become age-friendly across the entire continuum of care. So every individual that you interact with, we challenge you to think about the individual's mentation and mobility and medications and multi-complexity and what matters to them. And so you can do this with any patient at any age. And so what we do in our department as we're talking and teaching is we take this framework and apply it to every patient. And when we are having residents or fellows or students rotate with us, I ask them, what do you think you're going into? Okay, you think you're going in to be a cardiologist, or you think you're going into ID. How can you take this concept and apply it to the patients you're going to care for? So that's really what we're going to try to do today. And then in addition to that, I want to provide an additional framework to think about aging. So when we think about pediatric development, right, we have 1,000 different languages and words that we use to describe the different phases of aging, right? You can have the multiple phases of gestation. We have newborns, we have babies, we have toddlers, we have little kids, we have pre-adolescents, tweens, adolescents, teens, and that's just like up until 19, right? But when you're 21, you're an adult. And is a 50-year-old the same as an 80-year-old is the same as a 90-year-old? No, and you'll often hear people say, right, one 80-year-old is not the same as another 80-year-old. And so Louise Aronson writes this beautiful book, Elderhood. And if you haven't read it, it's a great book about aging. But she really breaks up aging and the adult lifespan into this concept of there's younger childhoods and adolescence. There's middle adulthood, which is what most of us here are. And then there's older adulthood. And then that older adulthood period, we really have to break down and think about. So that period where people are still really active, that's not the individual that needs a comprehensive wraparound care. As we think about our resource utilization, whether it's our own mental bandwidth or the resources of our limited communities, that might not be the individual that gets the most attention, right? There's the individual who then starts to slow down or has more medical complexity. And then there's the final period of disability, which none of us want, but the alternative is sudden death. Because unless you have sudden death, we all face a period of disability. And while that sounds gloomy and dreary on this beautiful spring day, it's what we all have to plan for and think about and know how to work with to keep that disability from impacting day-to-day life the worst possible. And so in this series from Louise Aronson, she shares wonderful quotes. And I just put a couple in today to bring us back to the patient who's in the room with us, right? And so one of the quotes that I love to pull that really normalizes aging, not as we shouldn't expect problems to happen. We should expect health, and we should aim for that as much as possible. So after a history and exam of the knee, the doctor said, "What do you expect? The knee is 95 years old." To which the man replied, "Yes, but so is the other one, and it doesn't hurt me a bit." So we should never be using aging as an example for why, or an excuse for why things aren't the best health that one of our patients should be having. So let's dive in. We're going to start by talking about mentation. And so I want to introduce you to a 57-year-old patient of mine. We'll call him Joe. And Joe presents to me, he's a patient in our HIV clinic through infectious disease. And he presented to see me with about 2 years of cognitive difficulties. He shared that he was having some challenges at work. He works as an IT specialist and was having more trouble with completing his tasks, staying on task. Not yet having difficulty with function, not yet having workplace impairment, but starting to really impact his ability to work. And he was starting to really question himself. When he's 57, we imagine he's going to be working for quite a bit longer, right? If his mentation is to the point that he can't work, what's going to happen to his lifeline financially? And is there something that we can do to improve his mentation? Is there something that's reversible? So when we think about mentation, we're not just thinking about memory, we're thinking about our whole cognition, who we are as people, how we interact with the world, our emotional regulation, how we communicate, how we receive communication, how we make decisions. We're thinking about mood and depression. We're thinking about isolation. The last couple of years, we've heard so much the power of isolation and negative impacts on health. Think about, does someone have happiness and purpose? Does someone have reason to get out of bed? Does someone have the capacity to make their own decisions? In this gentleman's case, he was very low mood. Does he have true major depressive disorder? Or is he so worried about his cognition that it's bringing down his whole persona and his whole being? And we have to treat that as part of what we're looking for as we look to evaluate him and take care of him in a comprehensive age-friendly care manner. We also have to think about capacity from a mentation standpoint to follow through on a care plan. I ordered an MRI, he didn't go. I reordered the MRI, his HIV navigator helped it make sure it got scheduled, he didn't go. I ordered it a third time, and now my nurse navigator is responsible for trying to make sure he gets there. And so we think about, right, also in mentation, one's ability to move forward with a care plan as we're trying to actually help people understand what's going on. So mentation is a really big bucket. You know, people can be socially isolated and lonely even when they're not alone. And in older adults, loneliness leads not just to unhappiness, but also to functional decline and death. Even living in communal settings, older adults who feel lonely and isolated feel, think, and function less well. They are physically active and are more depressed. The health impact of social isolation is equivalent to smoking 15 cigarettes a day. All else being equal, it increases mortality by 26%. I like to ask my patients, who are your people? Who are your people? Who are your people you go home to? Who do you call after work? Who do you see on the weekends? And Joe said nothing. And so when people come to me worrying about their memory and they have no people, I get worried because I don't have a care system that might step in to help them navigate the health system or help them if the mentation gets worse. I very intentionally don't ask who is your family, especially in our community in DC. In Chapel Hill, I asked who was your family, but in DC, I don't ask who is your family because so many people are aging independently or don't have families, and we have so much local violence, right, that often that can be very triggering. So I just ask, who are your people? Let's talk next about medications. This is a real pill box. It's not supposed to have lots of different colors and lots of different boxes. Monday night, Tuesday night, Wednesday night, Thursday night should kind of all look the same for the most part. And so when we're starting to think about our older adults, I know in the HIV population, medication compliance is so important. And so as I'm seeing Joe, I'm saying, are you taking your medications every day? I'm also going into the EMR to see if he gets his medications with us and to see if I can actually validate that. Is he actually getting his prescriptions on time? Trust but verify. And I'm saying to him, how do you remember to take your medications every day? What is your routine? Do you take them in the morning when you brush your teeth? Are they behind the medicine cabinet? And if you have evolving memory loss, you might not see them and be reminded. How do you know that you took one and not two? If you took it in the morning, how do you know not to take it that night? How do you second guess yourself if you're just like a little off and you didn't sleep well that night? Because the medication might not be dangerous, but another one they take might be. So if you start taking too much of your donepezil for memory care, you'll put yourself into anticholinergic toxicity, mad as a hat or hot as a hare. And so patients will do that all the time if they don't know, if they don't have a safe way to take their medications. So I ask people very specific questions, and there are a gazillion ways to organize and help people get pill boxes. We do a lot of bubble packing of medications. Our geriatrics program knows every pharmacy in the DMV that will bubble pack medications and deliver them to a patient's home so that they don't risk making an error by opening up all the bottles themselves. For those of you who are at MFA, we're trying to get our pharmacy to do that. So we're thinking about drug-drug interactions. We're thinking about adverse effects. You know, we look often at the creatinine clearance for the kidney to tell us if medications are accumulating. But in geriatrics, we often think about the liver as well because there's not a great marker to tell us that a deficits might, drug effects might be accumulating. And so we're always on the lookout for that. When we think about medications that in this gentleman, for example, I might not want to start if he's already having trouble with his cognition. If he was a woman, for example, I would talk to him about avoiding oxybutynin or anti-bladder spasmodic agents that might worsen his cognition. Let's go on to mobility. So I asked this lovely gentleman, Mr. Joe, how does he get to work? He currently navigates multiple forms of public transportation. How do you get to your doctor's appointment? The same. What happens when he starts to have trouble with his transportation? What happens if his mentation precludes him from doing that? So we have to know the systems in place in our community, like Metro Access. We have to ask for and screen for these types of topics. We also think about mobility much more broadly. How do you move, like physically? How do you take care of yourself? How do you do your ADLs and your IADLs? What does your life space look like? So most of us today have left our homes, gone to work, unless you have a beautiful work from home day. Maybe you've been in the car or the metro, your life space is big. But if Joe's memory starts to impair him from going to work, what happens to his life space? It gets really small. How does he interact with the world around him? What's going to drive him to connect with purposeful living with other people? I already asked him, he told me he didn't have people. How is he going to get his HIV care? How's he going to get his medications? And so we have to really think about this whole concept, right? His world is his work and his home. And outside of that, it's pretty empty. I won't talk too long with this group about IEDLs and ADLs since it's a health, it's a health audience. But I invite you, when you are working with people who have memory loss or have disability, to ask their caregivers. These are my two favorite questions. How long can you leave him or her alone? And if they look at you like you're crazy, like that doesn't apply to me, you're like, okay, moving on. We ask a lot of questions that people don't really, they're like, okay, moving on. But they might just be like, oh my gosh, I can't even leave him for 15 minutes. Like you wouldn't believe what he just gets so anxious, right? And so you can follow up with what happens when you do leave him alone. And so those are real gem questions if you do have people who are living with disability. And this is this concept of life space. And this research, if you want to learn more about it, is from UAB. And it talks about, as elders are aging in place in their community, we can really link health outcomes to their homebound status and how often they leave their home versus their yard versus their neighborhood versus their town versus their ward, if we're talking about the district. And when we know that people stop moving, when they stop walking, it's a major prognostic indicator for mortality. So gait speed matters. So when you're watching your patients move through clinic and you're like, can you get in the room? Or you're like, can we go to the bathroom, and you watch them walk, as they start walking slower, it is a major prognosticator for impaired function, reduced lifespan. This particular article by Studinsky and JAMA has some beautiful graphics that show the power of gait speed over many more comprehensive markers. Multi-complexity. So we've set the stage for aging being complicated. And Dr. Siegler showed on her very first slide that map showing the prevalence of individuals living with HIV was brightest or darkest red on the east side of our city, where we also have the most health disparities, the greatest access to limitations in access to food and housing security and medical complexity and transportation challenges and violence. And that is what multi-complexity is. It's taking Joe and thinking about the fact that he lives in a community with violence, where he doesn't have people. And if he develops disability or issues with his memory, how is he going to age in place in that community with memory loss? And so multi-complexity has us really thinking about elder abuse and neglect, food access and preparation, transportation and housing security, but also things like accessibility of healthcare, right? If he starts to have trouble with transportation and isn't able to come and see my colleague at GW, how's he going to get the great HIV care that we know is available in some places in DC? What if he didn't speak English? How would he be able to best communicate with us? As people age with memory loss, their ability to use interpreters becomes very challenging. And often a sign of cognitive changes evolving and really progressing is that someone who has late life learned English will become much more comfortable in their native language. And so we have to be careful when we're assessing for cognition that we're doing language congruent assessments or modifying our assessment to allow for and recognize what the native language actually was. Lastly, and not intended to be insignificant or less important, is gender, sexuality, race, religion, culture, and ethnicity. You guys know that we have such a high population of elders who identify as LGBTQI+ or in DC. And while the DC network is relatively accepting and open and has systems in place to care for these individuals, a lot of the country does not. And so as we think about aging elders who may have been isolated from their families or may not have designated healthcare power of attorneys or may have partners they did not choose to marry, we have to be very proactive about identifying healthcare power of attorneys, identifying people's wishes, and helping them actually put that documentation in place so that their wishes can be represented and acted upon by those that they would choose to have do that. Adult Protective Services tells us that our most vulnerable elders are those who are socially isolated, those who have poor family relationships, and poor family relationships by not that you fight a lot, by lack of depth or complexity in them, that there's just not a web of support. Individuals who are widowers, we know that financial exploitation is very high in this population. People who are younger than 70 are often targets of financial exploitation and emotional abuse, as well as our lower income older adults. We think also in multi-complexity about the concept of multi-morbidity, right? And so the American Geriatric Society provides us some really nice guidance for how we think about older adults who are living with multi-complexity. So these individuals that really have 2 or more chronic conditions. So perhaps Joe has HIV, but now Joe also has dementia, or Joe has HIV and Joe also has heart failure. And this is the place where we move away from real guideline-directed care to think more about care that is so patient-centered. So what are one's preferences? Does evidence actually exist that can be interpreted? One of our challenges in geriatrics is that so many of our patients are excluded from clinical trials because they're just complicated, and you want to study something with less variables. What is prognosis for that individual? And when we talk about prognosis, we step back and say, what does that prognosis actually mean, right? What is the prognosis of Joe developing dementia? What is the prognosis of Joe remaining independent in his home? What is the prognosis for Joe's HIV to remain controlled if he starts forgetting his medications and no one recognizes it? Right, so we think very broadly about all these things coming together as we try to put together clinically feasible plans that optimize his care. I'm just going to buzz for a second through some of these. And we talk about what matters most, right? What matters most to Joe? And so this concept of what matters most, it's not goals of care discussions or how does one want to die? It's how do you want to live? What is most important to you now? And so when I ask Joe, what matters most to you? What brings you joy in life? What matters most to him is knowing whether or not he's going to develop dementia. And what brings him joy in life leads to a very quiet response. And so I know that as I treat Joe, I not only have to get to the bottom of his memory loss, but I also have to figure out how to connect him to purposeful living and joy and try to build out his social network, whether that includes blood family members, friends, or reaching out to really try to connect to others. When we think about what matters, it's not just health goals, it's what are you looking forward to? It's if you did develop memory loss or you did have physical disability that shortened your lifespan, what are the things you wouldn't want to have left undone? What's on your bucket list? What do you dream of? We can talk to people very bluntly about, well, let's just do that. What's keeping you from doing that? So if Joe told me that his dream was to go skydiving, I'd probably spend a little time in my next visit asking him about that. What are his values? What are his personal preferences? And thinking about spirituality, we talk a lot in geriatrics and palliative medicine about spirituality, often because it's under-recognized. Spirituality not being religion, but being, oh, I just saw this message. I'm so sorry, DC CFAR. I will wrap it up. But spirituality being in the context of, what is your greater connection to the world around you, and what can you draw on for resilience in the face of disability? And fortunately, that is our final M. So I'll leave you with these 3 questions to think about asking your patients. What is the most important thing that I know about you as a person? What are the things that bring you joy or make you happy most days? And can you still do them? And what concerns you most about your future? It just opens up really incredible conversations, and you can learn so much about your older adults. And I'll stop there. Thank you so much. Sorry again for missing the chat, which I totally asked you to send me.
Not a problem at all, Dr. Prather. Thank you. It was really an amazing talk, and I'm sure we'll have some questions for you at the end.
Yes, definitely. Thank you. And yeah, we will hold questions to the end, so thank you. I'm going to introduce our final speaker, and we're scheduled to go till 6:30, so we'll have lots of time for discussion. So we are very pleased to have Dr. Susan Shepard join us to provide her perspective on current models for geriatric care in DC for people with HIV. She serves as the executive director of Terrific, Inc., a 49-year-old private nonprofit human services and housing organization with an emphasis on action. Terrific, Inc. offers a variety of services, including, among others, HUD housing, psychosocial support, early intervention, medical and non-medical case management services for people with HIV, and programs to address food insecurity. Dr. Shepard is a Howard University graduate. She received her Master's of Urban and Environmental Planning from UVA and has a Doctor of Healthcare Administration from Virginia University of Lynchburg. And she was referred to us by George Kerr. She has been a member of the DC CFAR Community Partnership Council. So Dr. Shepard, we look forward to hearing your perspective, and I'll ask you to take it away.
You're muted, Dr. Shepard.
Yeah, great. Okay, great. Good afternoon, everyone. I thank you and colleagues, friends, DCCFAR. It is indeed an honor to be here. Well, I guess this evening's been a long day. But anyway, and I also thank my dear colleague, Mr. George Kerr, for asking for my participation this afternoon. Dr. Siegler, Dr. Prather, I enjoyed your presentations. This sort of set the tone for what I will be discussing today. The slide before, which I can do this because I've been with Terrific for so long. We are a 49-year-old nonprofit organization, whereas we provide services for populations in crises. Way back in 1985, we provided our first program for children who were infected with HIV, whereas they were called the border babies at that time. So then afterwards, our executive director was one of the first directors for the Department of Health. The Department of Health has gone through some different name changes. Most of you know now is the Department of Health, HOSTA. So Terrific has been providing services for Ryan White even before Ryan White's services were actually in place. So I'm gonna go back just a little bit here. The current time, we provide core medical services in which they indicated medical case management, AIDS, pharmaceutical assistance through local pharmacy, early intervention services, support services, non-medical, health education, risk reduction, and psychosocial support services, whereas we provide pastoral counseling, social work support, nutrition education, and they also indicated based upon food insecurity and housing. So basically saying that just a little bit of information. I'm not going to go over some of the data that was already captured, but currently in the District of Columbia, because we are funded for Part A and the District of Columbia and also the EMA area, currently there's 11,747 current residents in the district, which is basically 1.7% of the population that are living with HIV. It is no surprise, a large segment of this population living with HIV, 74% are 40 years old and older, and 58% based upon those are 50 and above. So as practitioners, we know that is those that have been long-term survivors and also those that are newly diagnosed. According to the latest data from the CDC, give more of a broader demographic view, there are nearly 1.1 million people living diagnosed with HIV in the United States and dependent areas. The other thing, as you also know, is still a high degree of individuals that are older living with HIV. So we see here that as far as we can see here, 1 in 6 newly diagnosed in the United States are 50 years of age and older. What we want to think about, we've already heard about different reasons for barriers. Many of them, we as direct care providers, we work with a large segment and population that are underserved also low income, lack to healthcare, isolation, experience that include different social determinants, not receiving optimum health care. I was thinking about some of the conversations based upon persons that are living with HIV at this time. Primarily, a large percent of those that we provide care for are those that are not receiving care or have not been compliant or adherent. We also know, based upon comorbidities with a lot of older adults. I was telling someone sometime before when I was looking at the CDC, 50 was basically older adults. So I'm in that pool these days. So as far as for, we look at individuals that are 50 and older. And what comes with that is other additional comorbidities such as cardiovascular disease, diabetes, renal disease, cancer, and other complications to HIV treatments. During COVID-19, that exacerbated many of the health outcomes with our older adults due to isolation. I know Dr. Prather spoke about isolation as compared to smoking 16 packs of cigarettes per day. And that is something that we found out, that with our seniors, isolation, not only is it the isolation, but that means that it precludes many of the clients that we see to care. When we returned from COVID-19, we found that more than half of our seniors were not compliant with their HIV treatment and care. And so therefore, what you will find is an astronomical number of seniors that passed away from other comorbidities because they were not even keeping up with their medical care. Other issues such as behavioral health, depression, anxiety, substance abuse disorders, all of those are things that we find in direct care. Lack of adequate housing. If you don't have a home, it's very difficult to receive an environmental presence that would create different outcomes for your care. The other thing is that we found lack of transportation. Generally, you would desire for those that do not have acuity scales that require more than twice a year visitations, that they would be able to do so. So during that time, we have had all these different complexities that has impacted the outcome of the care of the seniors that we provide health for. Another thing you will find with seniors who are older, often disclosure. Frequently, we've had clients that their family members are not aware of their diagnosis, financial issues, insurance issues, medication management issues, illiteracy issues. So those are a lot of the barriers that we experience based upon service delivery. And so I think I covered most of them. Finance, legal issues, life circumstances. So those are some of the items that we experience on a daily basis with Terrific and Incorporated. Okay, so frequently people will say, what can you do about this? I would have to be perfectly honest. Oftentimes, as direct care providers, I'm one that I would say a privilege that I can have a private physician and I can pretty much navigate the care system. But oftentimes, for those that we see, case in point, I was rushing in today to participate. Case in point, we had a client, a male client, due to slumlord. They were moved out of their housing today. This is something that was being put in place since the early fall, whereas we saw linkages to care, linkages to services through legal counsel for the elderly to push that back to a certain extent. Unfortunately, they moved the person yesterday evening. And we were able to find someone to assist in navigating, moving their furniture. Well, the person has immobility on a walker, has had open heart surgery on 2 different occasions, neuropathy, whereas they have also unfortunately slipped and broken their ankle at one time. So I had a hysterical call that I sent to one of our medical case managers to assist the client. Well, unbeknownst to them, they thought they could go back across the street and they could bring their groceries to the new place that they would be staying. They discarded all of their food. The District of Columbia ranks number 10 based upon food insecurity and is even higher with seniors. So now we have a client who they have indicated they have mental health issues based upon depression. They have no mobility. Now they have no food, and it is 3 o'clock. That's called direct care. So at 3 o'clock, we have to identify a safe place where they can stay, simply because where they move them, there's no doors, and they're just going to be there for a short period of time. And so what I'm saying to everyone, there is a difference between when you do community engagement and you provide services. You have to think on a dime. So we had to provide this person with some type of food, shelter, and also they were just released from the hospital without their meds. And so when I think about service models, I really think about the supportive services, the integration of care, and who can you call to assist people that do not, maybe they can't navigate the system as someone else could possibly do so. Modern medicine and technology is wonderful if you know how to navigate the system. So what I would say is that's the real talk of seniors in silos that are seeking care and treatment in the District of Columbia. We have to meet people where they are. Oftentimes people cannot get to the clinic, or they cannot get to hospitals. And so as a direct care provider and looking at different models that are successful, one of the things I put down was empathy and relationship. You have to have the ability to understand and share the feelings of another person in order to help them. You have to have a relationship in order to coordinate the services. The other doctor has spoken about understanding the HIV care continuum. All of these things, when you work with people, we have all of these different terminologies and backgrounds, the 4 pillars of ending the epidemic: diagnosis, treatment, prevention, and how to respond. But the degree of importance is that you still have those organizations and people that are on the front line to assist people based upon after 4:30, after 5 o'clock. Those that cannot get to or have barriers that prohibit them to seek services. I remember we were selected as one of the age-friendly cities, age-friendly programs in the District of Columbia, because one of our models is that you really have to meet people where they are. And oftentimes it requires that you roll up your sleeves. During COVID-19, we had to expand our technology and work with seniors based upon contacting them through monitoring telephone calls, education through Zoom, where we provided through the Washington Home. I heard someone spoke about that before, iPads, where we also provided Medicare, Medicaid numbers, MediHealth, all those type of things. I think that what we really have to remember, because it would be simple for me to say, as our non-medical case management coordination, what a medical case manager is supposed to do. You're supposed to intake. You're supposed to assist. You're supposed to help with insurance. You're supposed to educate the client. You're supposed to improve their health outcomes. When we do early intervention, we're supposed to link them. We're supposed to treat them. When you have non-medical case mix housing, you have to provide subsidized housing programs and those type of programs that you can do partnerships with other organizations. We do know this, people are living longer, right? So people are living longer. That means that we have far more people to implement services and care. So when I think about different models, understanding the care continuum, interdisciplinary care models and development, and a big one is empathy and building relationships. And also, as researchers, as clinicians, we still have to have boots on the ground in order to understand how to care for people. Frequently, when you're in your office, sometimes, I think that it's hard to really paint a picture of what you may see in one day in the District of Columbia. Now, that's not just looking across these here United States, but you really have to look at the care needs, and then it's applicable to say, we want to have viral suppression. We want our clients to use art. We want them to participate in their doctor's appointments more regularly. We want them to participate in the coordination of care. But in actuality, the health literacy that is provided to clients is very something that we have to look at in care models, that they understand how to become more self-sufficient. Those are some of the things that we do every day as direct care practitioners.
About 4 minutes left, Dr. Shepard.
Oh, okay. I thought I was done. So as far as those are some of the items that we look at every day. And then we can look at the different initiatives where they say DC wants to end the epidemic or we want a cure. But those are the type of things that we look at every day when we provide services. There was one of our social workers used to say that you really have to have a strength-based focus on the strength of your clients. And oftentimes, clients can contribute to their care plans in order to achieve their goals. The purpose is to empower your client with awareness and strength. And then as a community advocate, we coordinate connections within the community to advocate for the rights and the help for our clients, that they can use existing medical care and treatment approaches. And then afterwards, you collaborate with that person. There was a question about who is your person? Who would you contact? And oftentimes that is another issue with many of the clients that we have. They do not have others. They do not have families. So they build up supportive families. So with our psychosocial support program, frequently we have support groups that we identify those other factors, whether you are a caregiver, a care receiver, or you need peers to help you navigate. So when you look at the continuum of care, we're very fortunate that we can coordinate all those different services together in order to create more of the optimum health outcomes for our clients. And so every day at Terrific, and I'm quite sure also where each of you return to, it's always a different day. So I always look at opportunities such as this to learn and to improve and implement the services that we provide. I've never had the same day in working in HIV for the last 35 years. So as far as I do applaud DC CFAR for having these type of educational sessions or events, because then you have takeaways. And so when you return, I always say, have empathy and create relationships with those that we care for.
Thank you so much, Dr. Shepard. That was amazing. And I want to thank all three of our speakers for three amazing talks. And I'm going to open the floor up to questions, which I'm sure there's a lot of. Just going to make two comments to about the things you said, Dr. Shepard, too. One is you said people are living longer. I think in the most recent report from the DC Department of Health, it mentioned 58% of patients living with HIV in DC are now over the age of 50, which goes to that point. And when you said we need to meet patients where they live, I'm really excited that DC has made a commitment to that with building the Cedar Hill Medical Center, because a lot of our patients do travel for more 7 to 8 to come and see us here in clinic, and that is a trek. And we're lucky that we sit right on top of the metro, but that's still, for some people, that's a challenge to navigate and have, that still leaves accessibility issues. And so I'm glad that DC is making that commitment, and actually our organization, the MFA, will be providing services at the Cedar Hill Medical Center. There were a couple of comments towards about Dr. Prather's comment about the age, the gait speed and mortality, and I'm going to open it up to, I don't know if Scott or Jules want to share some of their thoughts that they shared in the group, in the chat, in case other people didn't get to read those. Jules, do you want to go ahead?
So I have a few comments. First of all, thanks for your talks. It was good to hear everybody, particularly Dr. Prather's clinic, about her clinic in at GW, I guess, in Washington. So just a bit of a background. I started this whole discussion about aging. I was the first to recognize this problem 18 years ago. Since then, care for older and elderly people has not gotten better. It's gotten worse. In fact, in the past 5 years, it continues to get worse and worse and worse. And we are not prepared to provide adequate care for aging and elderly people. We don't do screening in the clinics. HIV doctors are generally uneducated and unprepared about how to meet the needs of the elderly population. So having said that, in the first talk, there was a little bit of discussion about the aging clinics that have been started by HRSA in New York City and New York State. I was the one that got New York City to open the first 3 aging clinics in New York. And I followed up with the state to get them to start the discussion to open up their 10 aging clinics. And I talked to Laura Cheever about the 10 HRSA clinics that they opened. None of them are meeting the needs of the elderly population. Care is getting worse. Each clinic sees maybe 100 people. There are over 200,000 people over 60 in the United States. 73% in San Francisco are over 50. 50% in New York are over 60, and it's going to get older and older and worse and worse. And people over 60 in general, 95%, I suggest, over 60 are not getting any of their care needs met. There's no screening for cognitive function, for bone mineral density testing, for frailty in any of the clinics. So it's very nice, and I've been doing educational webinars for years, just like this. But the bottom line is the federal government is simply not responding to the problem. Thank you.
Would any of our moderators care to respond to Mr. Levin?
I'm going to just comment that aging-related care can't be the responsibility of specialists, right? Because you have less than 6,000 geriatricians in the country, and most of us spend half of our time in academics or research. So aging care has to go out to everyone who's taking care of patients or clients. I know Dr. Shepard and I are going back and forth on language. So clients, patients, individuals, residents, community members, people. And so that is the whole point of the age-friendly care movement, is the idea that if we can all be just a little better collectively, we can be so much better if we all train ourselves and practice thinking about these things. I just threw a slew of resources down in the chat. The DC Brain Health website came out of our research, but is around dementia. But it's not only resources for individuals living with cognitive loss. It could really be used for anyone. You literally type in what do you need, and it shows geographically where it is in the district. The DC villages are communities that have risen up grassroots style initially, but now proactively supported in local communities. And for individuals who have Medicaid, and participation is usually free, and then the remainder of participation is on a sliding scale model. This is everything from grandma, please don't stand on the chair to change a light bulb, to someone who might pick you up and take you home if you live alone after a hospital stay and help you get your medicines and get food in your refrigerator. DC senior centers throughout the city are listed on this website and partner with great organizations like Terrific Inc., Iona Senior Services in wards 2 and 3, and the many other leading agencies for our wards in DC where these great resources are coordinated. You can pick up the phone. I regularly, with my patients in the room, pop out my email and email the email address for the DC Aging and Disability Resource Center when I'm with a patient, because we all know when we have things to do, there's that inertia of actually overcoming and doing it. So you can say individual's name, phone number, I'm sitting with them in clinic, they're having housing insecurity, and someone from the Aging and Disabilities Resource Center will reach out to them. And then DC PACE is our dual eligible program for individuals with Medicare and Medicaid in the specific zip codes who are eligible to participate are there. That is run by Edenbridge Health, who runs PACEs all over the East Coast and is really a phenomenal resource for comprehensive care for aging individuals who are dual eligible in our community.
Yeah, the only thing I would add to that, I think that it's very important that people seek provider patient-centered care. And the other thing is that with many of us that are here participating, advocacy is so extremely important in order to obtain the type of services or what you wish to have your as you age or whatever generation you happen to be in, that you have to buy into an advocacy and take the time to do so. I do agree with a lot of what I believe is Mr. Levine shared. It is very scary. And it's scary because when you treat people, you find out that technology has impacted in some positive ways, but it's also very difficult for certain generations to navigate to seek that care. And so when you say case managers and medical case managers or organizations such as ours that's community-based, it is very important that you identify someone just as you identify a specialist to assist you. Because I have, even at my office, I have numbers for numbers and organizations for organizations, but when you are dealing with cognitive or mental health or different issues, sometimes you cannot advocate for yourself. And so that's why I say, if you have a friend or a family or someone, it's important that they also guide you to contact an organization or a clinic that can assist you. But I do find that a lot of those services, technology has excluded people to a certain degree, and also with the economy, the funding is not what it may have been of the past days. So the thing is that there are a lot of different complexities of why we find ourselves where we are, but on the same token, speaking up, being heard, participating, and I always say to people, I want to participate, and I don't want to wait until I can't participate because of whatever type of health disparity I have. So I don't want to be in a situation then say, oh, I wish I'd done something or said something to increase my healthcare outcomes. But it is hard for people to navigate. And so we have to keep that in mind. If you come in contact with resources, do direct people to those resources.
Thank you for that. Scott, I think you have your hand up, and then Alan.
Yeah, I just wanted to piggyback on some things that Jules brought up. I'm 72 now. I've been living with HIV for 38 years. And one of the things that I'd like to comment on is I'm actually on my third HIV doc. Specialty docs, especially in HIV, are getting less and less available to us living with the disease. And this is only the second webinar that I've attended that's dealt with geriatric issues. So this has been extremely informative for me, and I would appreciate it if the three speakers would provide their contact information. I have a organization of people living with HIV across New York State that meets every Monday morning. And I'd love to be able to get you folks to come in and do a presentation when you're available. So if I have your email information, I'll be sure to reach out. Dr. Prather, your presentation really hit home for me because in the last 6 months, I've been dealing with a lot of physical issues. And just the mere fact that you brought up the importance of exercise, finding myself now at home, spending a lot of time on my laptop or in front of the TV. I'm not getting out walking like I used to. And then what I've noticed is a lot of lower back pain, a lot of hip pain from sitting so much, which has brought me to bone and joint for 3 cortisone shots in the last 6 months. So thank you so much for opening up my eyes to what my real problem is. I got to get back out and exercising.
Thank you for those thoughts. And I'm sorry that your HIV providers have been rolling over. It was, yes, was that because they retired, they moved? Was there another reason?
Retired.
Yeah. I mean, ID is a field where we are struggling to encourage or to get new young residents to join the field, and it's been struggling for years, and it's really a crisis right now. So the IDSA is well aware that we need to change things about reimbursement for people who choose ID specialty, so that we will have a robust pipeline of physicians for all our patients living with HIV.
My
Alan?
HIV peer educator position was actually in a residency program up here in Schenectady, and that was one of the things that as the new residents came in, I was trying to emphasize to them how important it is to keep HIV in your thoughts as to what you want to specialize in.
Alan?
George, you've been waving. Do you have a question?
Yeah, sorry, I can't raise my hand for some reason. I just wanted to say that, the DC CFAR in our reauthorization application, we're adding aging and to it as one of our SWIGs. And we're adding the word quality of life. And I think that that's really important for us to acknowledge that we are actually, as a CFAR, we can't do, we're not able to make changes on the local level with individual providers or for the federal government. But as a CFAR and trying to encourage our researchers to really look at what quality of life looks like for an individual, no matter if it's 50, 60, 70, or longer. And we also, there's no mention tonight, but we also have to remember our lifelong survivors. They are so important and they miss out in a lot of these conversations. So thank you.
Thanks, Mark. And my question for our 3 practitioners, thank you for your wonderful very informative presentations, is about the whole allied health team that it takes, both clinic-based and when you're moving out to where people are. I mean, the complexity of the issues you raised, it seems that there's issues for social workers, for physical therapists, for pharmacists, for nurse practitioners. How do you put together the ancillary support staff that's needed to provide the comprehensive care for people aging with HIV? And how, if you bring that out to the community, it just seems it gets even more complex, coordinating all the different services that may be needed. Thanks.
I guess I'll jump in go ahead, Dr. Shepard.
I mean, I think the biggest thing is that you do raise a a very difficult, it's also in the chat, sometimes it's too political. I think what happens is that as a nonprofit, we've been in existence in June for 50 years. It's always private-public partnerships. And so we're tasked with identifying the funding to put all of the different infrastructure in place. And so I think that when you have collaboratives where you have clinic and you also have community-based that work together, oftentimes you can create those partnerships, whereas maybe your fiscal budget does not allow. There is certain professions such as nutritionists or social workers based upon licensure during COVID-19. Some of those roles are difficult to find. They also spoke about HIV specialists and practitioners. Those roles or those type of areas, I think we have to bring back more interest in pursuing it, simply because oftentimes you can't find the people to put in place, even though that's also something that you could benefit for based upon creating optimal care. So there's a lot of different constraints. One, the biggest financially. Two, the interest of people going into certain areas of professions, maybe they're not as interested, and also looking for different roles to fill with practitioners that there's really not that many available or licensed. They are, it's hard to pull things together in order to provide care. So oftentimes, each of us, we want to, but you do have barriers that you try to achieve in order to create the best type of self-centered, focused care for those that we provide services to.
I guess I just add to that, at the end of the day, being part of people's lives is about relationships, and being a healthcare provider and trying to optimize health is about relationships. And so I, as a physician, know personally speech and language pathologists I send to, I know which physical and occupational therapists I send to, I know the social workers, I know the people in my community to care for the aged adults that when I need to pick up the phone and talk to people for, right, not the people who are active, retiring well, but that third part of older adulthood, which are the people where we really need to solidify our resource availability for, right? And I'd invite, the HIV community to think about the geriatrics community. So in geriatrics, we kind of have this back and forth toggle of like, is geriatrics a specialty and we want to stand alone and strong up here on this pillar? Or do we want to make everybody a geriatrician and like integrate? And I'd be curious, Dr. Siegler has probably heard this too over the years, right? Are we big G or little g? We make everyone able to care for older adults in an age-friendly way? Or do we really want to create these networks that are really geriatric? And so we can create these entire care systems to support individuals living with HIV. But in addition to that, we should probably tap into the many existing resources that already exist in the city to care for older adults. Because yes, there are huge gaps, but there is still a lot there to care for our older communities.
Let me just add one or two comments. One is that I see two sort of different aspects to this. One is how do we get these services paid for, and how do we expand the existing payment mechanisms to underwrite exercise, to underwrite pharmacists, to pay social workers, and so on. So part of this is changing the how we fund what we do so that the people who are most important get paid. The second part of this is access, and how do we create the mechanisms so that even if the individual professional can be reimbursed for their care, we find a way to link people to care. And we are all, as at least as clinicians, our focus is our clinical space. And I think one of the exciting things about some of these models of care is that they're taking place in the community. And what I would encourage is for CFAR to support or fund or study different models that provide the services that are needed to the community, so that we're not continually looking at, should the geriatrician be the primary care provider? Should the infectious disease person be the primary care provider? How do I get the person into my clinic? I think this is a wonderful opportunity for the main centers to say, we're going to go beyond the molecular biology to insist that studies be done of the most effective ways to provide care, and we have to insist that those mechanisms of care go beyond the standard models of the way care is done in the United States.
I love that challenge, and I will be talking to Anne and Alan about that. Thank you. I know we're over our time, but we've had two people had their hands up for quite a while, so I just wanted to give them an opportunity. Dorcas, do you want to go first, and then Marcia?
Absolutely, and thank you so much. I really enjoyed this talk with CFAR is doing in DC, and I enjoyed Dr. Prather, Dr. Siegler, and Jules, and everyone that's done something, Dr. Susan Shepard. But I just want to offer this one small piece of what we can do. So I'm a nurse at the School of Nursing at Hopkins, but I'm with the AETCs, Mid-Atlantic AETCs. And what we are starting to do, and we're initiating it right here in Baltimore, because we have two clinics that do aging assessments. We have University of Maryland Thrive and the Bartlett Clinic, and they're new at doing this. Neither one has done it more than 5 years. Bartlett Clinic just started doing it with a consultant maybe 2 years now. But I wanted to say what we can offer the AETC when I wear that hat, and I am an advocate for HIV and aging for many, many years. What we can offer are free clinical observerships. If there's any provider, a licensed provider that wants to come and spend a day and to see what an aging assessment or geriatric assessment looks like, that hour-long visit. And the same with University of Maryland. They have agreed. All you have to do is just email us or email me directly. We can set up that. That's a small step, but it's something, because these are not included in HIV clinics everywhere, and not all patients are in HIV clinics. Some see primary care clinics, and it can also be done there, but how to use a team approach, as Dr. Genie has said. But anyway, I'll just put my email in the chat, but that's a small thing, but I offer it, and there's no cost for that.
That is an extremely generous offer, and hopefully I will get an opportunity to take you up on that, because I have lots of patients who are aging with HIV, and I'm the de facto primary care doctor purely because their primary care doctors are too inaccessible or have turned over, and they are frustrated with trying to find new providers. So I find I am taking on more and more of their care, which I don't mind doing, but I do struggle with resources and time.
Thank you.
Marcia?
Yes, good evening, everybody. It's good to see everyone, and such a timely topic, and I'm so happy that CFAR is pushing it even further and more focus on this particular topic. I know it's been one that that we've been thinking about for a number of years in the CFAR, and I'm glad to see it being pushed even more. This whole aging thing and aging with HIV, it's a very frightening period. Sometimes, I mean, I'm 38 years long-term survivor, and sometimes it's as fearful as it was when there was nothing, trying to navigate all of this. And when we moved to a primary care, I'm not in a clinic-based care, but for primary care, under primary care from the ID doctors who are all aging and retiring as they have the right to do, and some are transitioning and whatnot. But at the time, they had to have their fingers on the pulse of the resources in the community, so they were able to point to you sometimes some of the resources that were available. But now that you maybe deal with a primary care physician and a numerous specialists, where there's very seldom a conversation about HIV in the specialties. No one has ever suggested a geriatrician to me, and I've never asked about it, which I probably should. But, you know, what I'm noticing is at this point that there isn't, you know, amongst all the people, especially as you see with all the comorbidities and everything, there's very little interplay between those things and HIV. You know, as an example, your endocrinologist might be suggesting Ozempic or something for you, and you have no clue what that means in terms of their interaction with HIV meds or other things, and nor is that ever spoken of. So I think that system also is broken up. But just as an ending, I like the presentations and really want to, you know, just emphasize the importance on focusing on what matters to the person. You know, and also get at, you know, what are the strengths? I mean, I think it came across, Dr. Prather, maybe is more of a deficit approach, and I would take more of a positive approach with people, because somehow they got this far, and sometimes tapping into what was it that got you this far? You know, what did you feel good about in your life? What are your resources, as opposed to maybe identifying upfront what they might not have. And so, and, you know, making them a part of their care plan. You know, some of these things are very basic things that we talk about a lot, but I think these days, because we all have to learn to advocate for ourselves, there's no one, you know, we don't have people advocating for us directly a lot, but we've learned to advocate. We, the community of advocates, have learned to advocate. And, you know, and kind of on a positive note, I did send a doctor a note today when she yesterday, and she's a gastro doctor, and she helped me to think through a quality of life issue that I had. I mean, you know, you don't have people kind of going a little further to show you, yes, you've lived a long time, but you're dealing with a lot of other things that impact on the quality of your life. And she went, you know, above and beyond what others may do to help me identify a solution to an issue that is not a life and death, but it's a quality of life situation. So I wrote it today to thank her for seeing me as a whole person, seeing me as a person with a life who wants to have as full a life as possible. So I just encourage us to do more of that with people, because this is a very difficult thing to age in this society with HIV. So thank you very much. And I know I need to now stay more connected, because there's so much I've learned and so much more that I need to learn myself. Thank you.
Thank you, Marcia. In the interest of time, I think we probably do need to wrap this up. I want to give our speakers a chance for any parting words. I think one of our attendants said they could go on for hours about this topic, and I feel like we could go on for a lot longer, but it's 6:40 and I don't want to hold people up. So if anybody has any parting words of wisdom, we're happy to hear them. Otherwise,
thank you again for a great webinar.
I appreciate everybody attending. I appreciate our three speakers. It really has been a robust conversation, and I think gives food for thought for, you know, where we as a CFAR can do more in the future. And like I said, I think Anne and I and Alan will be having conversations to that end shortly. And I appreciate everybody's interest in this topic. And again, thank you for your time, and have a good evening, everyone.
Thank you.
Thank you.
Thanks so much. I really appreciate